Nick, John again. I've got a question.
Yeah.
How do you, and maybe also Laura and Francesco could think of this. So the purpose of a DC, or in this case, the DCE, is to ask patient preferences. And how does that, the results of such a study, how are they considered in a decision-making progress from a health system or health clinical decision point of view? Because they're beyond the patient, there are other factors that need to be considered, like the feasibility, the availability of resources, the cost of a particular treatment option, for example, and the economic and the financial implications of different choices. So have you gone so far as to say, well, here are the results of what the patients have indicated, and then had to come up with some sort of decision-making process to, in a sense, balance each of those different elements of decision-making and to make a choice? How would you go about doing that?
Yeah. I mean, it's a good point, John. So one of the key aspects of high-quality healthcare is acknowledged as patient-centered decision-making. And so keeping the patients at the center of those decisions, but you can't say that that's the sole way of making healthcare decisions, because you've got patients who will make they prioritize their own health conditions, of course, and there are a range of other priorities from a policy perspective. You've got to cover the gamut of health conditions, and there are some health conditions that may not be as well represented by patients, and where you need to take into account the burden of disease and the potential for gain, and in producing healthcare policy, and the intersection in patient-centered decision-making with then going on to developing guidelines based on evidence or expert opinion, and the potential costs of any intervention that might be considered, takes I guess a lot of discussion and an overview, and I'm not sure what the best way of doing that is. Like, I don't think I can answer how everybody can be considered to have an appropriately weighted opinion on how policy and guidelines can be produced across different specialties. I mean, within oncology, sure, we can have that discussion and have a reasonable understanding of it. But in if you're thinking about oncology versus cardiology, or what do you prioritize? I don't know how to answer that. I'd be interested in how other people think about it.
Thank you, Nick. So I want to throw that to Francesco.
Yeah, well, I guess to Nick, there is a very short answer. That's why you need economists, right? But you need to try to trust them in using these instruments. I think what's interesting from Nick's presentation is clearly how you can bring this to a very, I would say, service level dimension, right? So the priority setting decision, because it is what is done, what Zolt is doing on the feasibility of a trial on sham surgery, right? Whether it's feasible, are we gonna ever hit the number of patients that we need? So that is basically a funding decision in the hand of an economist. So that is useful for us to understand ex ante, the feasibility of things, right? So it is a priority setting question. Clearly, everybody's very sort of focused on the importance of each areas of expertise and so on. But what a policymaker does when he's allocating resources, and I've seen this in practice, he does this or she does this, I would say, in what we refer to ad hoc manner. So the contribution, so it's not providing like a normative approach, right? So it's providing a positive way to look at what these wastes are among the different factors that come into play in a priority setting element. But it's obvious that the interesting exercise is the one that comes after. So once you have the weights in front of you, you have to decide, okay, an extra dollar for oncology versus cardiology or whatever Nick was referring to. In that moment, what you need to do is to understand really the impact of that decision, which is not necessarily captured in this piece of work. The follow-up piece of work that is needed to occur, it's what we did, for example, in this high-level priority setting discrete choice experiment. And we use those weights and we actually go and build what the actual delivery of healthcare services globally looks like if we base the health service delivery on the outcomes of the discrete choice experiment. And then with that in front and what it exists, then you have to make another assessment and a trade-off and then decide, because that's the ultimate trade-off. So that's why we speak as economists a lot about multi-level, multi-stakeholder approach. So this journey, I think it's a long one indeed. I think it's worthwhile because we can learn from these let's say multi-steps towards the ultimate decision on what to fund, what to service, how, and so on. But I would call it pretty much it's important to do it to be able to understand if you want and contribute to the implementation side of things. Without that bit, I think Nick is quite right. It remains, an exercise very valuable that informs the decision makers, but we need to do that extra step at the end and really look at this and evaluate what would be the services out there and what they are, and that is the real decision with all the attributes and outcomes and benefits and costs incorporated in that experience. And it is done. I mean, it is done in some occasions, and I would say that ad hoc decision making is becoming less attractive, also because the public has a very reactive approach to decision, and media plays a large role. And you've seen this during the pandemic. So our decision makers are very sensitive to things. So I hope I answered it. It's a very beautiful, complex question. So thanks.